would you mind just walking us through in a very simple form, how a patient can tell whether or not they should be receiving a procedure to open up their arteries mechanically, whether it's through, endovascular, which is wires and balloons, possibly some stents, even some roto-rooting devices, or even surgical bypasses, endarterectomy, where they scrape out the plaque, right? How does a patient know what they need?
Okay. This is the most controversial topic
Yes.
in cardiovascular treatment.
We didn't know what
today.
you were getting into.
All right, yeah. So I'm going to turn your question on its head, Kim. We're going to answer the easy questions first.
Okay.
I'm going to start at the end of the spectrum, the chronic limb-threatening ischemia patient, CLTI. CLTI is the end stage of vascular disease. It's when you have a limb with ulcers, either on the toes or on the ankles, that is caused by lack of blood flow. This is a situation where seeing a vascular specialist is critically important. These folks run the risk of major amputation, and it's not small. It can be 25% per year. And that's the number that came out of the most recent clinical trial called BEST CLI, which was published in the New England Journal of Medicine in November 2022. The other folks in this category of patient are the folks with rest pain. And those are the folks sitting on their couch that say, oh man, my foot hurts. And it's not leg, it's not thigh, it's not buttock. It's usually almost exclusively foot that is really the hallmark of chronic limb-threatening ischemia in the leg. This is another sort of person, maybe doesn't have 25% per year risk of major amputation, but it's high. It's 10 to 25%. It's in that range. Those are two groups of people who really should see a vascular specialist, whether it's a surgeon, cardiologist, interventional radiologist, whoever is serving your community, to take control of their peripheral arterial disease. It's a must.
Mm-hmm.
That's an easy question. The question of what to do, well, BEST CLI is a challenging study to analyze.
Yes.
The difference between open surgery and minimally invasive surgery is very tight.
Mm-hmm.
It was percentage point differences. And so as a vascular surgeon, it doesn't affect my practice so much. There are people in this category of patient that I treat minimally invasively. There are people that I treat with open surgery. I have both types of patients come to see me on a regular basis, and I offer both sorts of care up in Fallbrook. I think for folks in areas where there's only a cardiovascular specialist that can do minimally invasive work, it becomes a bit more challenging of a question to answer is, which should you do? I think the fundamentally important thing is that people see a doctor and even ask that question, because there are so many people that I've seen up in Fallbrook recently who have never seen a vascular specialist.
I think that's the bigger deal.
And they get, a toe amputated for one reason or another, and it doesn't heal.
Yeah.
And then they're really at risk for a major amputation, either below the knee or above the knee. And that's the whole reason we're doing what we do. You're doing what we do, and I'm doing what I do.
Yeah.
So to get into the weeds on which is best, I think is beyond the scope of our discussion. I really think that I encourage people in those two categories: wounds on your foot, pain in your foot, go see somebody.
Yep.
Then we can have the conversation.
And we always tell people to get a second opinion, and actually different doctors, different philosophies, different facilities, you might have different options available for you. And we really try to say, hey, less is more approach, and encourage the doctor, less is more, above and beyond. And if you are going to do endovascular, you probably would agree, you know what, less is more, kiss it with a balloon, try and cause less trauma is actually better.
That is 100% correct.
Yeah,
you're exactly right.
We still have a lot of doctors in some of the outskirts areas where it doesn't seem like the doctors may attend some of the advanced conferences that you and I have attended. We just got back from a conference last week. It was so great to see you over at that conference where they were talking about some of the new tools and techniques being used, particularly in some of the office-based labs. But the less is more is consistent with even the stenting. And we still have patients where the doctors are saying, we're going to do a procedure and we're going to stent. But that's a little bit old school, unless you're talking about the iliacs, the abdomen, or even the heart. You actually are adopting more of a philosophy like leave nothing behind if possible, right?
That is true. That is one of the major concepts that a lot of companies are really pursuing nowadays. The idea that you can put in a stent and have it last for 20 years, I think, is something that's falling by the wayside. A lot of treatment involves making sure that the tissue that was there functions unobstructed by a foreign body.
Yeah.
So there was a huge controversy about drug-coated balloons that I'm sure you're well aware of, going back to 2018. That has kind of calmed down, and now we're back using drug-coated balloons. There's other things. PQ bypass is something that folks have been using to route a stent through the vein so that it doesn't use arterial real estate to bypass a blockage. And then there are other things like reabsorbable stents. I think actually yesterday,
yes,
there was FDA approval of one of the stents
from
for
Abbott.
sale. Yes, a company performed a very good clinical trial that was presented, I think, in October at Viva, showing that it did better than just a balloon that was uncoated below the knee. And so it's another option that's coming for patients to ensure that your own tissue is really what persists for the lifespan of your treatment.
Can you, because for folks that don't understand, so you have the plain old balloon. The balloons are used to dilate the vessel. So they go in with a wire, they slip a balloon over the wire in an endovascular or minimally invasive way, just a little puncture right in your thigh or, in your groin or in your foot or wherever they're going to puncture to access your artery. And then they inflate the balloon to push that plaque aside, whatever type of plaque. And you have the plain old balloons, but then you have ones that have a drug on them. Can you talk a little bit about the difference between the two and why a doctor would use those drugs?
Sure. The drugs on the balloons are useful in many different areas of medicine. The drugs in these particular balloons prevent cells that cause the occlusions to form from continuing to grow. And the thinking is, if you have this drug present for a period of time after you treat the patient, it prevents the inflammatory process from going out of control and causing the artery to have an injury that then reoccludes blood flow. And it's been proven above the knee, and it seems now below the knee with this new stent to do just that. And so everybody's very excited about this option.
Can you talk about the bioabsorbable stent? We did have a question that came in from Alan just a little earlier today where he was asking, why is it, and you alluded to that a little bit in the beginning, but why is it that Europe has been able to use these drug-coated balloons, and especially below the knee, and the US has not, or they're just now getting these to become available?
Sure. Having been through the process of submitting things to the FDA for multiple reasons, I can tell you that the FDA is a tough customer. The amount of...
It's a good thing, though.
It's a good thing.
Yeah.
The amount of scrutiny that they put into regulating devices is far more extensive than Europe. And so when companies look to sell their product, it is common for them to go to Europe first to receive what's called a CE mark through the European Commission and go to market far years, sometimes decades before the United States. I'm thinking of a particular device that's involved in aneurysm care that's been available in Europe for going on 15 years, but is not sold in the United States to every vascular surgeon. It's only available at about 10 centers around the country.
Wow.
And it has to do with some of the details of the regulatory environment in the United States versus Europe. And so that's the reason that below the knee stents are not as common in the United States. Having said that, you as a physician can put in stents as an off-label use, and coronary stents are very often used for that purpose.
Yeah, I've seen that.
So I can tell you that despite the terminology off-label use, there is still a high degree of safety for using stents below the knee in the United States. There becomes a bit of a challenge from a medical legal standpoint. However, it is safe, it is effective, and it is widely done in the United States, but just not in an on-label sense.
And talk about the bioabsorbable stents. What are those and why are they different?
So bioabsorbable refers to the body being able to break down the material that is deployed by the physician. The exact composition of the Life BTK stent, I think, is still proprietary. And so I can't tell you too much about the structural details of that. What I will say is that it is encoded with drug as well. I think it's everolimus is the name.
Which is a cancer drug.
Yeah, that is true. And that everolimus has a proprietary way of being affixed to the bioabsorbable stent, and then slowly it's released over time, allowing for treatment of the peripheral arterial disease below the knee.
And we have a Dr. Gupta. We had mentioned that the bioabsorbable stent was supposedly going to be available very soon. And it was just approved the FDA. And he brought up a good point that there's another device. It's called SPUR, SPUR, which he was saying that, you know what, I don't know, maybe use that, maybe use the SPUR instead. And that's the stent that has the thorns on it that you can actually leave in for about 6 minutes, and then you take it out, and it's by reflow.
So that's interesting. I don't know about SPUR. I know about Serenator. What you're describing is a very similar device to the Serenator balloon that's Cavant. Peter Schneider is the inventor. He's actually one of my former faculty at UCSF. The SPUR I'm not familiar with, so you've given me some homework there.
No, this is a good point. I always talk to you that different doctors have different access to different tools at different times, especially when they're getting ready to come to market. They can't deploy a device out to every single person until it's actually approved, but even then it's a slow process of rolling that out. And right now, this device, the SPUR, which is a stent, it has some thorns in it, in a sense that they call it a removable stent. It's available in Europe right now, but they're still in clinical trials, as Dr. Zarkowski was mentioning, that it does take a little longer here sometimes to get to market with a more stringent FDA approval process. And they're not expecting that to be available until Q1 of next year. But right now it's available in a few sites who are part of the clinical trial.